So as I said, this is going to be rapid. I'm going to start by talking a little bit about the data from the Cancer Genome Atlas, which has looked at both squamous cell cancers and adenocarcinomas. A fresh look at the optimal application of standard modalities, and a very important national or international study that's currently ongoing. A little bit of an update about targeted therapy, which is, as people probably know, has been a little bit more disappointing in esophageal cancer than it has in some other solid tumors. And then immunotherapy is in early days in esophageal cancer, but exciting, and we'll talk about it. So first, for squamous cell carcinoma, this is the TCGA. You can see how much this looks like other squamous tobacco-associated malignancies like squamous cell cancer of the lung or head and neck cancer. The most common mutation that you see there is the tumor suppressor P53. Notch is also mutated, as we see in head and neck cancer, and once again, this is a loss of tumor suppressor function. And then CDKN2A and cyclin D1, also among the most commonly mutated. Moving to gastric cancer, and the reason I'm including gastric cancer is, as you all know, the majority of the esophageal cancers that we see in this part of the country now are distal esophagus and GE junction, and very often, because they're adenocarcinomas, they're studied together with proximal gastric cancer, and there's a paucity of studies that are really clean about which cancers they include. So the Cancer Genome Atlas analysis of gastric cancer, which includes GE junction cancer, confirmed that there are 4 principal genomic signatures. There's an EBV-related type of gastric cancer. This is less likely to involve the GE junction and is less common in the United States. There's those patients who have microsatellite instability. They're of particular interest because they're obviously very good candidates for immunotherapy in later states of disease, and then genomically stable and unstable cancers. And if you look at the CIN, which is a large group, you can see that mutational burden is somewhat higher in this group than it is in the genomically stable, but not as high as the MSI. So for patients who are newly diagnosed with esophageal and GE junction cancer, it's really important to do careful staging, both for metastatic disease and for the local extent of cancer. And endoscopic ultrasound is still the most useful tool for deciding what is the depth of invasion of the cancer into the wall of the esophagus. Very important in making decisions about neoadjuvant therapy. PET has been shown to be prognostic and is also very sensitive for distant disease in this cancer, and so is routinely done. HER2 amplification and overexpression has been shown to guide therapy in gastric cancer and GE junction cancer, but as well there are trials looking at this in intrathoracic esophageal cancer, and so we routinely do HER2 testing, even if we're not going to be doing fuller genomic profiling, although at my institution we often do that as well. The only group of patients who should be taken directly to surgery if they have esophageal cancer are those with T1N0 cancer. So any nodal involvement or any higher T-stage cancer should be an indication in patients who are fit for it for neoadjuvant therapy. And as people are probably aware, there are 2 ways of doing neoadjuvant therapy. The gastric cancer model that was developed in the UK by David Cunningham's group, where you get 9 weeks of chemotherapy before surgery, you go to surgery, and then whatever they find, you get another 9 weeks of chemotherapy afterwards. Or the chemoradiation followed by surgery, generally with no more systemic therapy after the operation. And the randomized trial that established that combined modality was a superior mode of managing these patients compared to surgery alone was the CROSS trial. Because of the fact that the systemic therapy is less in CROSS than it is in MAGIC, and the principal way that these patients fail is with distant disease, and because of the morbidity of radiation, there is some interest in figuring out whether or not their patient selection criteria or whether overall one of these strategies is better than the other. And in Europe, there is a large randomized trial currently ongoing comparing CROSS with MAGIC. So here are the data from the CROSS trial. So I'll just remind you, this was 44 gray of radiation with weekly carboplatin and paclitaxel. A more tolerable regimen than some of the regimens that had been piloted in the US that went more to like 52 gray and that used cisplatin and infusional 5-FU. However, as I was mentioning, it's less systemic therapy than those regimens would have been. So this has been reported with a median follow-up of 45 months. The median overall survival was significantly higher for the patients who got chemoradiation followed by surgery compared with surgery alone, going from 24 to 49.4 months. There was a highly statistically significant difference and persisted at 5 years. I don't know how well you can see the figure at the bottom, but what I'd like to highlight for you is that the 75% of the patients who were on this trial had adenocarcinoma, and only 25% had squamous cell cancer. But the power of the difference was driven predominantly by the squamous cell cancer patients. So here are the squames with surgery alone, and here they are with chemoradiation followed by surgery. And these two lines that are much closer together actually represent the adenocarcinoma patients. If you look at the forest plot, you can see that the dots are all on the favors chemoradiosurgery side of the plot, but the squamous cell cancer, even though they were a much smaller group, is more significant than the adenocarcinoma, with a p-value for the adenocarcinomas of 0.07. As well, those patients who had poor performance status, probably a minority of the patients in the trial, but they did not derive as much benefit either. And then this sort of gets to our educational question. One of the things that was kind of striking about this was that there was less impact on distant metastases in the cross trial than there had been in MAGIC. And so with the early results, a 6% reduction in distant metastases for the use of chemoradiation before surgery in the cross trial, as compared to a 13% reduction in the MAGIC trial. This, these data were, I'm sorry, I don't know why this isn't advancing. These data were updated in Lancet Oncology last year, looking at local regional progression, distant progression, and overall progression. Again, even with longer follow-up, the differences are durable and significant for all of the endpoints, local regional progression, distant progression, and overall progression. But if you focus in on distant progression, it goes from 48% to 39% with neoadjuvant chemoradiation, less of a difference than we saw with the MAGIC data. When I was at Fox Chase, we used to debate in the GI tumor board all the time whether, now that CROSS was a phase 3 trial and it was statistically significantly better to use that kind of chemoradiation compared to surgery alone, should we give up our older strategy of using a little bit more aggressive chemoradiation regimen with cisplatin and 5-FU. And ultimately, Walter Scott, who was the thoracic surgeon we worked with, got sick of listening to us bicker about this, and he got one of his fellows to pull all the charts and look at the outcomes. And so obviously this is not randomized data. There may have been a little bit more of a bias to pushing towards cisplatin for patients who were fitter, as well as for patients probably who were a little bit more worried about their disease. And the cisplatin was used for many years before the carboplatin-paclitaxel schedule was adopted. But so taking all of this with that kind of grain of salt, we did appear to see that the carboplatin-paclitaxel was providing less benefit than the cisplatin 5-FU, and that whether you looked at freedom from recurrence or death, there was the platinum-based arm was performing better. The thing that actually got my attention most powerfully from this analysis was this bottom curve over here, because we had always said if you got a pathologic complete response from chemoradiation, you had a very high cure rate, upwards of 72% in multiple series. And you can see here patients who had a path CR who were treated with the chemoradiation light of carbotaxol and 44 gray had a substantial risk of recurrence of disease despite having attained a pathologic complete response. And so I think this leaves the question open that's being addressed in the European trial of chemoradiation versus the MAGIC approach. To date, we don't have direct comparative data to answer whether additional systemic therapy after surgery would benefit patients who are treated with CROSS. There's some interest in undertaking a randomized trial in this space, which I think is quite likely to be centered around the use of immunotherapy, given data that I'll be showing you a little bit later. Okay, so I mentioned that HER2 expression in gastric cancer is associated with difference in the way we manage the patients. These are from the old intergroup chemo-RT after resection for gastric cancer trial, showing that the use of the adjuvant therapy appeared not to benefit patients who had HER2 amplification. Oh gosh, I'm not quite pointing this in the right place, I guess. It's worth looking at these data in metastatic gastric cancer, again, including GE junction cancer patients. They screened 3,800 patients in the TOGA trial. They found 584 who had HER2 positive cancer, and then they were randomized to a fluoropyrimidine and platinum, or the same thing with trastuzumab. And as you can see, there was a significant advantage both in terms of progression-free survival and overall survival, bringing the overall survival above a year for the first time in metastatic gastric cancer for the addition of trastuzumab. It wasn't clear, there wasn't a long history of looking at HER2 in gastric cancer the way there had been in breast cancer. It wasn't exactly clear what the test was that should lead you to say that the gastric cancer was HER2 positive. And so they explored a couple of different cut points. But if you looked at those patients who had IHC 2+ or 3+ and FISH positivity as the most clearly HER2 positive cancers, if you looked at the comparison for chemotherapy alone or chemotherapy with trastuzumab, a very significant difference for the addition of trastuzumab there, with a median survival of 16 months. And so we have the same question in esophageal cancer, where HER2 is also overexpressed and amplified in the adenocarcinomas. And so this is a RTOG trial. It's completed accrual. The results have not yet been reported, but looking at trimodality therapy that incorporates or does not incorporate trastuzumab. As with other GI adenocarcinoma malignancies, there is a potential role for HER3. HER3 overexpression has been associated with a worse outcome, lower overall survival in series of patients with resected gastric cancer at many places in the world where gastric cancer is endemic. And I have survival curves up there for you from Brazil, Japan, and China. And so this led to an interest in whether or not HER3 could be targeted now that there are some agents that will do it. I did not trot out, again this year, the slides that I did show last year about the failed attempts to incorporate EGFR targeting into management of esophageal and GE junction cancer. But there have been numerous large trials with mazatumab, cetuximab, and panitumumab, all of which were negative, possibly because of the high prevalence of downstream mutations. And that probably explains the sadness of our experience with HER3 as well. So MM111 is a monoclonal antibody from Merrimack that co-targets HER2 and HER3. And this was taken forward in a randomized phase 2 trial chaired by our former trainee, Crystal Denlinger, at Fox Chase, for patients with esophageal GE junction or gastric adenocarcinoma. And they had to be HER2 positive, whether by traditional criteria of being 3+ or HER2+ with IHC 2+ with FISH, or they could be non-traditional, which is to say they were non-amplified by FISH. And patients were treated with paclitaxel, trastuzumab, and MM111, or paclitaxel and trastuzumab, in each of those two cohorts, and that trial was entirely negative. Another receptor tyrosine kinase target that's been of interest in esophageal cancer is IGF-1 receptor. This receptor and its ligand are overexpressed and associated with worse outcome in esophageal cancer. Preclinical data had shown that if you inhibit IGF-1R signaling, you can suppress tumor growth and invasion, and that there's a synergy with chemotherapy. So within ECOG, we did a randomized trial for second-line therapy, patients who had progressed on first-line therapy with a platinum-based regimen of paclitaxel or paclitaxel together with the IGF-1R-directed antibody sixatumumab, and that trial was entirely negative. As you heard about in squamous cell cancer, The advent of Rama Serum AB has reopened the question of whether or not anti-angiogenic therapy can be helpful. The AVAGAS study with bevacizumab is now sort of an older trial, and I didn't bring that forward again today. But there had been quite a lot of interest based on high response rates and early, phase two type designs that we would be able to see a benefit of bevacizumab in this cancer. Those trials had all been negative. But now ramucirumab's been brought forward and compared to placebo in patients with second-line therapy, or patients who had failed first-line therapy for gastric or GE junction cancer. As people know, this is a monoclonal antibody that's targeted to the VEGF receptor 2. It exerts its anti-angiogenic effect predominantly on neovessels, but esophageal and GE junction and gastric cancers are among the solid tumors where VEGF receptor 2 can be expressed directly on the tumor cell and potentially have a growth-promoting role in that location as well. And so these were patients who had received first-line therapy with a platinum agent and a fluoropyrimidine and progressed and were going on to second-line therapy, where there was a comparison between ramucirumab and best supportive care. And as you can see, this led to an improvement in overall survival and in progression-free survival. Like a lot of studies in pretty sick patients, you see this pretty interesting thing where the first restaging shows progression of disease in nearly the majority of the patients. But this separation of the curves, once it happens in the progression-free survival, does hold for a number of months. And this is, I believe, a useful therapy in a selected group of patients. Other targeted therapies that are of interest include the PARP inhibitors. There's hypoxia in these cancers. This is one of the cancers that people with BRCA mutations can develop. And it turns out that ATM and P53, which may increase susceptibility to olaparib, are among the commonly abnormal genes in this cancer. So there was a randomized phase 2 trial, 123 patients, randomized to paclitaxel with olaparib or paclitaxel with placebo, and there was a pre-specified subset analysis for those patients where the ATM expression was low. Unfortunately, there was only about 14% of the patients. And what was very interesting about this trial was that olaparib added to paclitaxel did not improve progression-free survival really in a significant way at all. It went from 3.6 to 3.9 months. And if you looked in the ATM low group, that was a little bit more striking, going from 3.7 to 5.3 months, but that was a very small group and that wasn't statistically significant. And then, and this starts to be more reminiscent of immunotherapy, but olaparib, as far as we know, is not all that immunogenic. The addition of olaparib to paclitaxel improved overall survival, and it went from 8.3 to 13.1 months, and the hazard ratio there was 0.56, and the p-value was 0.005. So that is a mysterious finding, and whether it's because there was enough of a benefit of the olaparib that the patients were in better shape for subsequent lines of therapy, whether olaparib sensitized to subsequent lines of therapy, or whether, as the authors of the article speculated, there are durable effects of olaparib on clonogenicity. I think that remains unanswered. I actually was the person who wrote the editorial about this paper for JCO, and I have to say that I was skeptical about the benefit in overall survival in such a small study with no meaningful difference in progression-free survival. And I went back and I read all of the preclinical papers that they had cited and saw that really the preclinical model was not ATM low, it was ATM low with disruption of P53. So I said that in the editorial, and I got to ASCO this year, and they had gone back and they had done that work. They had characterized the P53 in the samples from this study, and if you, maybe I don't have time to walk you through all the different curves, but what they've done here is they've looked at each of the therapies, olaparib, paclitaxel, paclitaxel alone, in each of the 4 subsets, ATM low, P53 mutant, ATM low, P53 wild type, and so forth. And it does appear as if P53 does not impact the benefit of olaparib in the ATM low group. So this is actually a pretty interesting finding, although it's difficult to exactly break down why it should be behaving this way, but there's a phase 3 trial ongoing, and I think we'll learn more. And then I don't need to justify the study of immunotherapy at this late hour in the day, because I think you've heard it mentioned by many speakers, but PD-L1 expression, which is obviously one of the hallmarks of therapies of cancers that are sensitive to immune checkpoint inhibition. PD-L1 expression seen in about 60% of gastroesophageal and gastric cancers. And I'm very fond of showing this picture of my patient. He knows that I show it. He's the first person I treated with immunotherapy for a GE junction cancer. That was actually it was right before Thanksgiving. It was 4 years ago now. He's still alive. He takes these fabulous trips. Here you see him slaughtering elk in Wyoming. And every trip he sends me a picture. I've seen him parasailing in Albuquerque, or parachuting in Albuquerque, and all these different things that he does. So as in other cancers, we are beginning to suspect that some of these responses can be very durable. This is from the Muro paper that was just in Lancet Oncology a couple of months ago, showing that many patients derive benefit in terms of tumor shrinkage. As with other cancers, the responses can take a little bit of time to declare themselves, but among patients who are responders, responses can be quite durable. As with other solid tumors that are not melanoma, pseudoprogression appears to be quite rare. I think that you can see one patient here who has a convincing RECIST progression followed by a decline. And I think, given that I'm totally out of time, I will not go through the biomarker data there. But I want to highlight a couple of ongoing trials. Nivolumab is also active in this disease with a response rate of about 12%, and there's a large phase 3 adjuvant trial for patients who have margin-negative resected cancer, who've had chemoradiation followed by surgery, gone to surgery. The surgery's resulted in negative margins, and they're being randomized to nivolumab or observation. And I think this builds on some of our concerns about how we can amplify the results of the CROSS trial. Keynote 181 is a second-line trial of pembrolizumab versus investigator's choice chemotherapy. There are numerous early-phase trials of novel combinations. MSI patients are expected to have the highest response rate, and we tend to reach for immunotherapy earlier in those patients. So, and the Javelin trial, patients with previously treated gastric or GE junction cancer be randomized to avelumab versus physician's choice. Primary endpoint there is also overall survival. So in summary, went away. What I wanted to say was that combined modality therapy, whether it's chemoradiation-based or chemotherapy-based, is the optimal approach for locally advanced disease, anything greater than T1 and 0. HER2-positive disease, if it's GE junction, we incorporate trastuzumab. If it's higher up, we should be seeing trial data about that very shortly. Rama Serum AB has activity. Immune checkpoint inhibitors have activity. And thank you very much.